So hi, welcome back. So today I'll be talking about non-fibrotic interstitial lung disease. Specifically, I'll be talking about interstitial lung diseases that don't have an apparent quote-unquote cause. So this is part 14.2 A in an approach to chronic dyspnea. Previously in this series, I have covered fibrotic interstitial lung diseases and imaging the diagnosis of fibrotic interstitial lung disease. So naturally, the next step is to go for the other interstitial lung disease, that is non-fibrotic interstitial lung disease. So essentially, any alveolar interstitial process that doesn't fall under the broad heading of fibrotic ILD, that is UIP, NSIP, and to some extent organizing pneumonia, falls under this category. And I'll be covering this topic under the following headings. One, I'll talk about issues with classification of this form of ILD, proposed classification, that is the classification that I use. We'll talk about non-fibrotic ILD that is not associated with an exposure to exogenous toxins or antigens. Under this category, I'll be talking about granulomatous ILDs. Specifically, I'll be comparing granulomatosis with polyangiitis with sarcoidosis. We'll compare them mechanistically. This will be a superficial comparison for now. We'll obviously come to the details of this comparison in our series on clinical immunology and rheumatology. Then we'll talk about a comparative clinical presentation of the two disorders. After that, we'll talk about what I like to call angiocentric granulomatous disorders, which are differential diagnoses of these, of particularly granulomatosis with polyangiitis on imaging, but clinically usually are not associated with the same type of presentation. So under that, I'll be talking about one specific type of lymphoma, that is a TFH lymphoma, angioimmunoblastic, what was formerly called of angioimmunoblastic T cell lymphoma. So I'll be talking about this specifically because it is angiocentric. Then also we'll talk about lymphomatic granulomatosis, which is a lymphoproliferative EBV associated disorder. So we'll get to that. Then I've already discussed eosinophilic lung diseases previously. Then we'll talk about what is bronchocentric granulomatosis. Specifically, I'll talk about how it is not really a disease. And then we'll finish off by talking about lymphocytic interstitial lung diseases and specifically talking about lymphocytic interstitial pneumonia and also some other lymphocytic disorders that affect the lungs. This is the classification schema that has been used in Harrison's Principles of Internal Medicine. This is from the 21st edition. So as you can see, biggest bucket that they've divided it into is ILD of known cause and of unknown cause. So the issue with this is, what do you mean by cause? Okay, so essentially what we are trying to imply is that in known cause there is an exogenous cause that is causing it, or there is a systemic disease that is known to be predisposing to this particular presentation or this particular lung pathology. However, as you can see, they have covered sarcoidosis and hypersensitivity pneumonitis into both cause, known and unknown cause. So this causes a little bit of confusion in itself, and so I don't really like classifying disorders like this. I do believe that you should classify them based on known cause and unknown cause, but I like to use the word etiology because cause can mean pathomechanism or it can mean etiology. There can be multiple etiologies that converge upon one particular pathomechanism. So clinically, it makes much more sense to use exposure to a known antigen as the surrogate for the word cause. So I use that. And my biggest issue with this is that, again, sarcoidosis is clubbed under ILD is of unknown cause. If you think cause means pathomechanism, we do know the pathomechanisms of sarcoidosis. And in some certain cases, sarcoidosis also results from exposure to specific things like organic dust. So it just creates confusion. The most important issue with this framework is that it is not amenable to a clear and easily derived diagnostic framework. So instead of this, what I do is I first decide whether or not an ILD is fibrotic ILD, because again, the evaluation of fibrotic ILD goes into what we have previously discussed in this series. And then I see whether or not there is a exposure to an exogenous toxin or there is no exposure to an exogenous toxin. So when there is no history suggestive exposure to an exogenous toxin and the patient has got non-fibrotic ILD, I like to use histology or histopathology to classify. So for that, I classify them into granulomatous, eosinophilic and lymphocytic disorders naturally. And in cases where there is associated exposure to an exogenous toxin, there are only two diseases that fall under this category. So that is granulomatous disorders, that is hypersensitivity pneumonitis, and smoking related interstitial lung disease. So today's talk is going to be about these disorders, and in the coming two talks I'll be talking about the usage of imaging in the diagnosis of these disorders. Okay, so coming to non-fibrotic ILD that is not associated with a history of exposure to exogenous toxin. In case of ILD, which is not associated with exposure to exogenous toxins, as I've said, I like to divide it into granulomatous, eosinophilic, and lymphocytic. So starting with granulomatous disorders, this can be with vasculitis or without vasculitis. So when it is with vasculitis, it is granulomatosis with polyangiitis or eosinophilic granulomatosis with polyangiitis. These two entities can only be differentiated with each other based on the serology and the presence of peripheral eosinophilia or tissue infiltration with eosinophils. So for the sake of this discussion, I'm going going to use GPA as a surrogate for eGPA. And without vasculitis is sarcoidosis. Comparing granulomatosis with polyangiitis to sarcoidosis, both conditions have granuloma formation. However, GPA can have coexistent necrosis, which is due to vasculitis. So vasculitis is there in GPA, and that is an ANCA-mediated vasculitis. So it is not a antigen-antibody complex deposition-mediated vasculitis. So because of that, it can show a gravity-dependent distribution, but it may also not. So we'll discuss this further when we talk about GPA in itself. Sarcoidosis, however, has no vasculitis. Upper respiratory tract is very common in the clinical presentation of GPA, and in fact, we differentiate GPA from eGPA and microscopic polyangiitis based on this. In sarcoidosis, upper respiratory tract involvement is rare, and the reason for this is because all of the T cells are being used up in granulomata within the lung and other organs. So as a result, they develop something called peripheral anergy. However, when it is very florid, particularly in patients of African descent, you do get a particular entity called lupus pernio that can at times even result in a saddle nose deformity. The pulmonary disease in both disorders is very common radiologically, but symptomatic disease only occurs in a sizable minority of patients or a subset of patients. Both diseases, most importantly, can co-occur with and be triggered by mycobacterial infection. So just because you have ANCA serology positivity or you think it is sarcoidosis based on imaging, that doesn't necessarily rule out TB, especially in places that have high base rates of tuberculosis, like India. Renal involvement is by very different mechanism in these two diseases. In GPA, it is ANCA-mediated vasculitis. So the patients have a rapidly progressive glomerulonephritis, specifically type 3 RPGN. All patients, again, with GPA, even if they do not have azotemia, that is elevated serum creatinine, or any features of renal dysfunction, require a routine microscopy of the urine to rule out any impending renal involvement if there are active sediments that almost always progresses to RPGN if unrecognized and untreated. On sarcoidosis, on the other hand, the mechanism is rather interesting. What happens is there is florid granuloma formation, and these are non-caseating granulomata. So these macrophages express 1-alpha hydroxylase, vitamin D 1-alpha hydroxylase, and as a result, activate 25 hydroxyvitamin D into 125 hydroxyvitamin D. However, they do not express sufficient numbers of vitamin D receptor, so there is no negative feedback. They produce 125 hydroxyvitamin D in a unchecked manner, and that ends up causing vitamin D dependent hypercalcemia. And as vitamin D also suppresses PTH, that results in not only hypercalcemia but also hypercalciuria. Okay, out of proportion to the degree of hypercalcemia. So a lot of these patients actually develop nephrocalcinosis, which naturally presents as chronic interstitial nephritis. Now, another thing that can happen is you can have bilateral parotid enlargement that can occur in patients usually of Caucasian descent. This is specific for sarcoidosis. So this is again a somewhat of an upper respiratory tract involvement in sarcoidosis. The combination of this with prolonged fever and uveitis, with or without a facial palsy, because there is granulomatous inflammation in the parotids, and that can infiltrate the facial nerve as it passes through the parotid gland. This entity constitutes the Hereford syndrome, which technically could also be called an upper respiratory tract involvement. So when I say upper respiratory tract involvement is uncommon in sarcoidosis, that is true, but there are two named clinical entities that present with upper respiratory tract involvement also in sarcoidosis. Now, coming to joint involvement, this is something that often is that is used to differentiate between these two entities. When you initially see a patient in GPA, the joint involvement is very common, almost universal, and any synovial joint can be affected. Could be a large joint, small joint. It could be asymmetric involvement, symmetric involvement. The absence of gravity dependence is actually quite specific for GPA. That is when joints are involved, they're not involved in a gravity dependent manner, as in it is not bilateral ankles or bilateral ankles and knees. It's not like that. Okay, so in case of sarcoidosis, it depends on whether you're talking about acute sarcoid arthropathy or chronic sarcoid arthropathy. With acute arthropathy, we have something called Lofgren syndrome, which is a combination of hilar lymphadenopathy with bilateral ankle periarthritis. Not arthritis, it's periarthritis. So the patient has a lot of pain around the joint and more pain with passive movement than active movement, and significant swelling all around the joint. This in combination with erythema nodosum is then given the eponym of Lofgren's disease or Lofgren syndrome, and we'll be discussing more about Lofgren syndrome later. In case of chronic sarcoid arthropathy, pulmonary parenchymal disease, that is fibrosis, becomes more common, and that is actually a chronic additive symmetric small joint predominant arthritis involving the small joints of the hands most commonly, and usually not sparing the DIP joint, unlike RA. So that's how you differentiate it from RA. Now, in case of skin involvement in GPA, again, it's very common. It's those it's palpable purpura because it's a small vessel vasculitis, but there can be features of medium vessel vasculitis because again all vasculitides overlaps to a certain extent with the adjacent size of vessel. In sarcoidosis, again, the skin involvement is very common. There is dermal granulomatous infiltration. These lesions, you do not undergo any degeneration because it's just granulomatous infiltration. And when you do diascopy, that is, you use a glass slide to press on the lesion, there is an apple jelly appearance. These are routine MCQ questions that are asked, so I've just covered them here. But importantly, the most important thing to understand is that there is no vasculitis in case of sarcoidosis, whereas vasculitis is pathognomic in ANCA. And we use this clinically as well as radiologically to differentiate between the two entities. Again, apple appearance on diascopy is actually not specific for sarcoidosis. It can occur in any granulomatous infiltration of the skin. So, yeah, so as long as there is no thickening of overlying skin, that is, there is no acanthosis. So, for example, even when you have tubercular involvement of the skin, you can have apple jelly involvement. Even in nodules that formed in leprosy, you can have that. Now, coming to the next topic in this discussion, we need to talk about what are called angiocentric granulomatous lesions. This is a term that is used mostly in radiology literature, but I like using it because it allows me to compare to otherwise, two entities that I would find it difficult to, associate with these two disorders. That is lymphomatous granulomatosis and, technically speaking, pulmonary lymphomas. But I'm specifically going to talk about T follicular helper lymphomas, angioimmunoblastic, because that shows significant angiocentricity and therefore fits the bill, that is the term angiocentric granulomatosis, best. Okay. The pathogenesis of and T follicular helper lymphomas in general and angioimmunoblastic nodal lymphomas will be discussed in detail in an upcoming talk on the non-Hodgkin lymphomas arising from mature T cell lymphomas. Okay, non-Hodgkin mature T cell lymphoma. So this here, as I just discussed, has been used as a representative example of a mature lymphoid malignancy that is involving the lung and shows angiocentricity as well as some granulomatosis. Now, importantly, like I said, imaging cannot technically differentiate this from any other lymphoma that might be showing some angiocentricity. So we'll get to that in the next video in this series. So coming right to it, comparing T follicular helper lymphomas, angioimmunoblastic from lymphomatoid granulomatosis. Pathophysiologically speaking, as I said, TFH lymphoma is a T mature T cell non-Hodgkin lymphoma. Overall, it constitutes just 1 to 2% of all NHLs. It interestingly has MDS or myelodysplastic syndrome like mutations, and we'll come to that. The founder mutations that you find in myelodysplastic syndrome, TNT3A, etc. We'll come to that. IDH2 and TET2, etc. Are also there in TFH lymphomas, and it's a very interesting pathogenesis. So we'll discuss that in detail there. In lymphomatoid, yeah, again, will be discussed there in detail. Okay, so that will be under approach to generalized lymphadenopathy part 2, that is T cell non-Hodgkin's lymphomas. Lymphomatoid granulomatosis is an indolent T cell NHL again, which causes a desmoplastic M1 polarized tumor associated macrophage response, and all of this has been initiated by Epstein-Barr virus infection. So this is associated with an EBV infection. Okay, and clinically, TFH lymphomas have very prominent constitutional features, which constitutes fever, unintentional weight loss, and hepatosplenomegaly. But they also have autoimmune cytopenias. This is because these are T follicular helper, cells that have become neoplastic, or neoplastic cells with the T follicular helper phenotype. So they can activate oligoclonal B cells, and that ends up producing autoimmune cytopenias and sometimes other autoimmune phenomena as well. Lymphomatoid granulomatosis has got two very characteristic extrapulmonary involvements. One is skin nodulosis, which is present in up to half of the patients, and neurological involvement. This can be a little odd because it doesn't get explained by the pulmonary involvement. That is seizures, stroke, as well as ataxia. So this is because of direct involvement of the central nervous system, and this has been variably, been reported to occur in 20 to 50% of patients. The prognosis of a TFH lymphoma angioimmunoblastic is not very good. The median survival at 5 years is around 32%, which is, as we've discussed previously, poorer than that for idiopathic pulmonary fibrosis. The prognosis with lymphomatoid granulomatosis is variable. Like I said, CNS involvement in lymphomatoid granulomatosis occurs in 20 to 50% of cases, and additionally, mass-like lesions can also be present in the liver and the kidney in another 20% of cases, but they're usually asymptomatic. Now, we've already discussed eosinophilic ILD in under part 13.3 in an approach to chronic dyspnea, so I'm not going to talk about this again. And as we've discussed it there, these are predominantly alveolar processes and proximal airway processes, so they don't technically come under interstitial lung disease. Now, as a caveat, there is a term that is thrown around, that is bronchocentric granulomatosis. This is actually a histological descriptor used to denote the presence of peribronchial or peribronchiolar infiltration by neutrophils or eosinophils or both, which results in secondary necrosis and formation of foreign body Langerhans cells. So clinically, around 2/3 of these patients don't have associated eosinophilia, and 1/3 have associated eosinophilia. So often, you will find literature classifying it variably as either a granulomatous disorder or a eosinophilic disorder, lung disorder. In reality, it is neither. It is a histopathological term that is used. It's not really a disease. And So therefore, there are many etiologies or diseases that are associated with this, and they can be classified into infectious and non-infectious disorders. Among infectious disorders, the two most commonly reported are mycobacterial infections and aspergillosis. And however, there is obviously another subset of literature that says that in order to diagnose this, you must rule out an infection. So again, that's just going into the weeds of the classification, and it's unnecessary. It's not unnecessary detail; it just creates confusion. So. And the other disorders that it is associated with is, as expected, other granulomatous disorders, that is rheumatoid arthritis, granulomatous with polyangiitis, and eosinophilic granulomatosis with polyangiitis. So this is a term that can cause confusion, so we should be wary about that. We should know what it implies. Now, importantly, although there is fibrin deposition here, it is not around vessels. So technically, this is not an angiocentric granulomatous disease, as I have discussed previously. That would be a pulmonary lymphoma with some angiocentric involvement, for example, a T follicular helper NHL or angiomaplastic, or a patient with with lymphomatoid granulomatosis. Now, coming to the last part of the discussion, lymphocytic interstitial lung disease. This technically only includes lymphocytic interstitial pneumonia, which is based on histopathology, showing lymphocytic infiltration into the alveolar septa. Now, there are some other clinical and imaging findings that are there. Clinical findings are very common, but the imaging findings that is most commonly associated with the word LIP is cyst formation. However, cyst formation is not mandatory for a diagnosis of lymphocytic ILD, and not all patients have cystic lung disease. So that is an important caveat to understand. And as I've already discussed under fibrotic ILDs and the pathogenesis and clinical features, lymphocytic interstitial pneumonia actually falls on a pathomechanistic spectrum along with NSIP, that is non-specific interstitial pneumonia and organizing pneumonia. Now, because of that, the patient profile of LIP is the same as that of the NSIP and OP, particularly when it is associated with a systemic autoimmune rheumatic disease, that is a SARD. Those cases show a strong female predominance and occur at a younger age. Both all three of these diseases are the result of type 1 interferon production within the lung, and this results in one of three reaction patterns. That is either prominent lymphocytic infiltrate plus or minus cyst formation, that would be LIP, prominent mixed cellular infiltrate and fibroblastic proliferation resulting in occlusion of the airspace with fibroblastic foci, that would be organizing pneumonia, and prominent interstitial fibrosis, either cellular or proper collagenous deposition, that would be non-specific interstitial pneumonia. So that's why these are just three faces of the same pathophysiology. So because of that, the associations are also very similar. So lymphocytic interstitial pneumonia is associated with three systemic autoimmune rheumatic diseases, that is rheumatoid arthritis, primary Sjogren syndrome, and SLE. But again, dermatomyositis also could be included in this list, because again there is type 1 interferon production. Antisynthetase syndrome can also present like this. It's just that antisynthetase syndrome tends to present with rapidly progressive ILD when it is present, and that obviously is not going to look like lymphocytic interstitial pneumonia. Okay. Then in addition to that, there are five disorders that must catch your attention when you're thinking of LIP. C stands for Castleman's disease. Now, Castleman's disease technically doesn't cause LIP. That is a specific type of lung involvement in Castleman's disease. But again, because of confusion in literature, it has been associated. So if asked, yeah, maybe it is associated. Second is amyloidosis. Amyloidosis again causes a type of form of cystic lung disease, and is technically not LIP. So again, this is probably because of the literature getting there being an overlap between the two because of confusion regarding the definition of the entities. Then it is associated with Hashimoto thyroiditis, T4 thyroiditis, CVID, that is common variable immunodeficiency. However, the more common lung involvement in CVID is a granulomatous small airway disease. Okay, that's a different thing altogether. And finally, H stands for HIV AIDS. Okay, so LIP ILD is thus associated with multiple systemic autoimmune disorders, all coming under the the pathomechanism of intrapulmonary type 1 interferon production. So all three ILD subtypes are also associated with GI autoimmune disorders, and these are the three GI disorders that actually cause ILD, that is inflammatory bowel disease, primary biliary cholangitis, which may co-occur with the inflammatory bowel disease, and your autoimmune hepatitis. Now, as far as the clinical presentation is concerned, as we've discussed that NSIP presents with chronic dyspnea, which is gradual and progressive, and initially exertional, and eventually with minimal exertion, associated with a dry cough. On the other hand, organizing pneumonia is something that presents with a subacute onset of dyspnea and prominent inflammatory features. LIP has both features, so it can present with prominent constitutional features, that is fever, hepatosplenomegaly, unintentional weight loss, and significantly elevated inflammatory markers. And in a subset of patients, it can progress to exertional dyspnea also. We've seen that the response of steroids in NSIP is variable but better than UIP ILD. However, in comparison to that, in organizing pneumonia, actually it is excellent. Most cases respond, although there is relapse in around 50% of cases. LIP has got a very variable course, and we'll see how that is. Now, we saw that the mortality rates in case of NSIP were around 18% at 5 years, with a cellular variant of NSIP having better prognosis. And organizing pneumonia has excellent prognosis. It may recur, but is always responsive to steroids. LIP is, however, associated with very variable prognosis. So around 30% of these people progress to idiopathic pulmonary fibrosis. That is a UIP pattern ideally. Additionally, another 30 to 50% of patients just have spontaneous resolution, and another 20 to 30% present develop into a lymphoid malignancy, that is a pulmonary lymphoma. So it can be very difficult to tell these patients what exactly is going to happen to them, and that is something that you must keep in mind when evaluating uh, a patient with suspected LIP. The possibility of a lymphoid malignancy involving the lung is something that really needs to be addressed, and often even during initial presentation, because of the presence of these B symptoms, that is fever, hepatosplenomegaly, and unintentional weight loss, patients are evaluated for a hematological malignancy. The initial evaluation is not the only time that evaluation needs to be done. Sometimes you have to keep evaluating or keep the patient on follow. There are other lymphocytic lung disorders. So what are those? That depends on the anatomical location of involvement. This is the lung. You can see the trachea and the primary bronchi, and I have drawn the lymph nodes, that is the mediastinal lymph nodes, as well as the bulk, that is bronchosocial lymphoid tissue, as the secondary lymphoid organs that are normally located there. Now, distally within the lung, this is a bronchopulmonary lobule, and inside that we have lymphatics, as we've discussed previously, and the lymphatics actually look like this. So taking a larger view of that, the lymphatics drain both around the central part of the lobule like this, and they drain along the septa, and we've seen that nodulosis along this pattern results in a perilymphatic pattern because of this. So now I have drawn some ectopic tertiary lymphoid tissue at the entry of the bronchopulmonary segment. So these nodes naturally are going to be called secondary lymphoid tissue, that they are lymph nodes. Then you can have bronchus-associated lymphoid tissue, which is also a secondary lymphoid organ. So secondary lymphoid organs basically bulk. And then we have the entry into the bronchopulmonary lobule, and there we have some ectopic tertiary lymphoid organ formation, and this happens only with chronic immune activation. So example that could happen in primary Sjogren syndrome. Similarly, such involvement can occur in the lymphatics at other sites. So you can end up developing a perilymphatic pattern also. So this is the same, that is, it is ectopic tertiary lymphoid organ formation. The lungs have secondary lymphoid organs in the form of lymph nodes, and when there is non-neoplastic involvement of lymph nodes, that is lymphomatoid granulomatosis. Okay, it's a lymphoproliferative disorder on the borderline with neoplastic disorders. Whereas when you have lymphadenopathy, otherwise it is, and it's neoplastic, it is a mature B or T cell lymphoma. Now, once you go a little bit more distally, you have the bronchi, and they have obviously bronchus associated lymphoid tissue or BALT, and involvement of this when it is non-neoplastic is called pulmonary nodular lymphoid hyperplasia, and this is considered as a precursor lesion to a maltoma or a mucosa associated lymphoid tissue lymphoma. So maltoma, the correct term for that would be an extranodal marginal zone lymphoma. Now when it is neoplastic, then it is extranodal marginal zone lymphoma or maltoma. Then as you go even more distally, you can have ectopic formation of tertiary lymphoid tissues, like within the walls of the terminal bronchioles. So that is then termed follicular bronchiolitis. And when it becomes a malignancy, then this is uncommon, but it is usually an aggressive B cell malignancy, typically a diffuse large B cell lymphoma more than other aggressive lymphoid malignancies. And if that involves the alveolar interstitial, that is lymphocytic interstitial pneumonia. So since the general topic is that of non-fibrotic interstitial lung disease, I have initially talked about lymphocytic interstitial pneumonia, but I cannot just leave this the other entities aside. Overall, lung involvement by lymphoma is almost always by primary lymphoma. Secondary lymphomas, that is systemic lymphomas, affect the lung, but that is always a DLBCL, almost always. Other secondary lymphomas account for less than 2% of all lymphomas affecting the lung. So out of these primary lymphomas, the vast majorities are maltomas or extranodal marginal zone lymphomas, but you can have involvement by Hodgkin's lymphomas as well as non-Hodgkin lymphomas, other non-Hodgkin lymphomas. The only way to differentiate this is actually by histopathology. As I have said, if there is angiocentricity on imaging, which we'll discuss in subsequent talks, that indicates that it may be a T follicular helper lymphoma, angioimmunoblastic, or a lymphomatoid granulomatosis. So that brings us to the end of this video. In this screencast, I've talked about the classification that is given in Harrison Principles of Internal Medicine. I have proposed a different classification. We've talked about non-fibrotic ILD that is not associated with exposure to exogenous antigen, that is without cause, which I like to classify using the histopathology. That is, we've started with granulomatous ILDs. We compared granulomatosis with polyangiitis to sarcoidosis. We've seen that mechanistically how they're different. GPA has vasculitis, whereas sarcoidosis doesn't, and both have granuloma formation, but sarcoidosis naturally has a non-cacheating granuloma. We've compared the clinical presentations, and we'll go much more into the details of these clinical presentations in our upcoming series on clinical immunology and rheumatology. And then we talked about other angiocentric granulomatous disorders. Specifically, we talked about T follicular lymphoma, angioimmunoblastic, and lymphomatoid granulomatosis, comparing the two. Then we briefly mentioned that interstitial lung diseases can also be eosinophilic, but as I've said, these are primarily disorders that have alveolar or proximal airway involvement. Then we discussed bronchocentric granulomatosis, and this is basically a disclaimer saying that it is not a disease, it is a histopathological descriptive term, and therefore the associations can sometimes result in it being clubbed under either a granulomatous lung disease or even an eosinophilic lung disease. Then we talked about lymphocytic interstitial lung diseases, compared LIP to NSIP and OP, that is organizing pneumonia, but also talked about other the spectrum of lymphocytic lung disorders, because we'll again also be discussing this under imaging in 2 videos from now. So that brings us to the end of this discussion. Thank you for watching, and I'll see you next time.